Bismillah ar-Rahman ar-Rahim. This is Dr. Ashraf Al-Midany, Professor of Pediatric Cardiac Surgery. Today we are going to present this lecture titled Surgery of Congenital Heart Disease. Of course, this topic is a very big topic. However, we are going to concentrate on the main items, and our target is to explain the anatomical basis for these surgical conditions and describe the presentations, how to diagnose those patients, what are the relevant investigations for accurate diagnosis, what to do as a preparation for the operation, and what are the principles for the surgery for those patients. The congenital heart disease, we all know that it results from the defective embryonic development, and the main period at which the insult may affect the heart and results in a major defect, congenital heart disease, is between 3 to 8 weeks of gestation. According to this slide, we can see that the organogenesis for the heart is between the 3rd week and the 8th week. So any insult to the mother or insult during the pregnancy at this age will result in a major morphological abnormalities in the heart. The etiological basis for the congenital heart disease is either primary genetic factors runs in the families, and the other one is the genetic environmental interaction, which is the major etiology, is 90% of the cases. Regarding the primary genetic factors, either chromosomal factors, as for example trisomy 21 or trisomy 18 as Down syndrome and Turner syndrome, or mutant gene as a recessive or dominant gene. The genetic environmental interactions, either multifactorial inheritance with the majority of the cases, or the risks to offspring of unaffected parents, or environmental contribution, as we just discussed, that any insult, as for example the drugs, alcohol, amphetamines, and convulsants for the mother, or infections of the mother as rubella or Coxsackie virus, or maternal conditions, diseases as diabetes, lupus, or an old age of the mother, may result in the major etiological, major morphological abnormalities of the heart, and results in a congenital heart disease. The incidence of congenital heart diseases, the main disease is the left to right chance, is about 53%. BDA and ASD, VSD, atrial septal defect, ventricular septal defect, or atrioventricular septal defect. The right to left shunt is 11%, is the tragedy of Fallot, tricuspid atresia, pulmonary atresia, either with intact ventricular septum or with a ventricular septal defect. The third one is the mixture lesions, as transposition of great arteries, or univentricular heart, or double audit right ventricle with truncus. Where the fourth one is obstructive lesions, as 15% of the cases, as aortic coarctation, pulmonary stenosis, mitral stenosis, or LVOTO, the left ventricular flow tract obstructions. Or the fifth one is a valvular lesion, congenital valvular lesion, either stenosis or regurg, or Epstein valve, which is the disease of the tricuspid valve, and miscellaneous as congenital arrhythmias or vascular rank. To go to diagnosis of the congenital heart disease, we should know that early diagnosis of congenital heart disease means better results. We need to intervene, or by surgery or by whatever intervention, as early as possible. This results in a very good results and prolonged very good survival. 40% of the congenital heart disease can be diagnosed at the first week of life, because it's symptomatic either by the shunting, or by the cyanosis, or by the failure to thrive, difficulty of feeding, chest infection. 50 to 60% diagnosed at first 2 months, because, as we said, the presentations is variable and all can present early. Others are usually later during medical examination, especially in the small lesions or the valvular lesions. The diagnosis depends on the good clinical history and good medical examination and investigations. So what to do in the history for the diagnosis of congenital heart disease? We need to know the age of the patient. As we said that the congenital heart disease, when present in the first week of life, it's either a severe disease or can be a very risky disease. So we need to operate upon or intervention. We need this intervention as early as possible. Also we need to ask for feeding difficulties, vomiting, lethargy, increased respiration, rapid respiration, tachypnea, hypoactivity, and failure to thrive. As we said, all these symptoms we need to ask for, and they are the symptoms for a presence of congenital heart disease in this infant. All may be a manifestation of congestive heart failure also, if the disease is a big disease and severe disease. The differential diagnosis for congenital heart disease, which share the same symptoms, the infant or the neonate can present with sepsis or metabolic disorder or hypothermia or others. All these differential diagnoses shares the same symptoms with the congenital heart disease. However, with the examination, we can differentiate more. Also, for the older child, ask for history of dyspnea, history of tachypnea, shortness of breath, or orthopnea, or swelling, or palpitations, or convulsions. All of these also are symptoms for congenital heart disease. Regarding the physical examination, which gives more information towards the congenital heart disease or other differential diagnoses, by inspection we need to see cyanosis, a clubbing of the fingers, tachypnea, prominence of the pericardium due to cardiomegaly and right heart side enlargement, jugular veins engorgement in the older children, and any associated defects as Down syndrome, Digeorge syndrome, Turner syndrome. Focal neurological lesions can also present to the patient. By palpation, we need to palpate the pulses, the rate, rhythm, volume, all the characters of the pulse, cardiac impulses and thrill, hyperdynamic pericardium due to the shunting, hepatosplenomegaly due to obstructive lesions, and sacral edema and lower limb edema in older children. Also, by auscultation, we need to auscultate the first heart sound, which presents the AV valve closure, and this is best heard at the left lower sternal border or the apex. And the second heart sound, which presents the semilunar valve closure, which is best heard on the first and second intercostal space. Normally, there is normal splitting, as we know, but if it's not splitting, if it's a single heart sound, it may present aortic atresia or pulmonary atresia because one of the both semilunar valves is lost, or fixed splitting, as is the pulmonary stenosis because of the shunting, or we can hear the murmurs due to left to right shunt or right to left shunt or the obstructive lesions. Also, in the physical examination, the blood pressure is a very important parameter. It's difficult actually in the neonates and infancy. However, the methods, either by sphygmomanometers with the different sizes of cuffs according to the weight and the size of the baby, or the flash method, or palpation method, or even Doppler method if it's difficult to find a sphygmomanometer with appropriate size. The wide pulse pressure can be in aortic insufficiency or atrioventricular septal defect or BDA. The low blood pressure in the heart failure, pericardial tamponade or cardiomyopathy. Also, and the difference in blood pressure between upper and lower extremities can present in coarctation. So the blood pressure is one of the important parameters in the physical examination, which may pick up the diagnosis for a certain congenital heart disease because it's characteristic for this disease. To go to the investigations, we can do the CBC either to see the polycythemia or anemia, because polycythemia, if the child is cyanotic, and the hypoxia can stimulate bone marrow for more production of RBCs, results in polycythemia, or anemia due to heart failure or failure to thrive or difficulty of feeding or etc. Chest X-ray to see the heart size, either cardiomegaly or small heart, and shape, the ECG for the heart rate and the axis and the rhythm, either left ventricular hypertrophy, right ventricular hypertrophy, or clock. Echocardiography, of course, is the cornerstone investigation for the congenital heart disease and can pick all the diseases, most of the diseases, if not all the diseases. The MRI to see if you need more sophisticated investigations, to pick more sophisticated small criteria for the diagnosis, especially for the right-sided heart and cardiac catheterization. In cases of cyanosis, we need to differentiate if it's a cardiac cause or a lung cause. Can be done by a hyperoxia test. We all know that if the patient is cyanotic congenital because of the cardiac disease, the BO2 is not a factor in the issue. The neonates with the cyanotic congenital heart disease usually do not have significantly raised arterial BO2 during administration of 100 oxygen. On the other hand, in the lung causes, if we administer 100% oxygen, can raise BO2. So it is a test for differentiation between a cardiac cause or lung cause for a cyanosis. The congenital heart disease to be corrected in the neonates, this is due to severity of the case, and we cannot wait for a neonate to grow up and operate upon. So those anomalies are critical aortic stenosis, hypoplastic left heart syndrome, interrupted aortic arch, symptomatic severe coarctation, transposition of great arteries, obstructive total anomalies, pulmonary venous connection, truncus arteriosus. All these we can see and notice that all those diseases, either severe obstruction that cannot survive, the neonate cannot survive with, or due to obstruction to the circulation inside the heart, as obstructive transposition, obstructive total anomalies, pulmonary venous connection, or a severe exposure of the lung to a very high flow, as a truncus arteriosus, severe pulmonary hypertension, or cannot in the TGA. In the congenital heart disease, due to be corrected in infancy. Cardiac anomalies with the pulmonary outflow tract obstruction, as in double inlet left ventricle, critical pulmonary stenosis, tricuspid atresia, double outlet right ventricle, double outlet left ventricle. And to be corrected in infancy or later in childhood as a VSD, atrioventricular septal defect, non-obstructive total anomalies, pulmonary venous connection, coarctation, double outlet left ventricle, or severe aortic stenosis. More in the childhood can be corrected also as the ASD, partial atrioventricular septal defect, VSDBS, coronary artery anomalies, and valvular heart diseases. What are the surgical indications and optimal timing for the operation? Our operations in the congenital heart disease, either closed heart or open heart surgery. In closed heart surgery, as a palliative surgery, systemic pulmonary artery shunt, as the praloctausic shunt, cavopulmonary shunts, as what we call Glenn shunt, or RVOT reconstruction, the valvotomy, patch widening, or valve conduit. The systemic pulmonary artery shunting, we need it according to the age and size and anatomy. We need it just to make mixing more in the child and raise the BO2 slightly as a palliative stage towards the correction later on. This is in the cases of complex anomaly with severe cyanosis, irritability, and hypoxic episodes in critically ill patients, especially in neonates and infants, which also can benefit from pulmonary artery growth later on for later correction. In cases of pulmonary artery bending, it's indicated to decrease pulmonary blood flow and protect the lung from severe pulmonary hypertension, which may facilitate later correction for those patients and protect vascular bed diseases. This is in cases of multiple ventricular septal defect or single ventricle unprotected. Our protection in the single ventricle for later Fontan operations, or even preparation of left ventricle for arterial switch operation in cases of transposition of great arteries with intact septum. Atrial septectomy to increase effective pulmonary flow and systemic oxygen saturation. Decrease the tendency of indication due to early total correction or intervention. Indication of atrial septectomy is transposition of great arteries, tricuspid atresia, or pulmonary atresia with intact septum. The beta and ductus arteriosus, it's open communication between the upper descending aorta and the proximal portion of left pulmonary artery. Significant BDA is indicated usually after first month. If the heart failure or failure to thrive may be indicated at any time or later than earlier than the first month. This is to protect severe pulmonary hypertension. Coarctation of the aorta, this is the last closed heart surgery, is the congenital narrowing of the upper thoracic aorta adjacent to the beta and ductus arteriosus. It's indicated when the reduction of luminal diameter more than 50% or with the heart failure at any age. Coarctation with the ventricular septal defect either to be done in two-stage repair to repair the coarctation first and then later on the VSD, or in one-stage repair, or other coarctation with other important endocardial defects usually can be done in one-stage repair. The open heart surgery, we have three items in the open heart surgery. Is the atrial septal defect. This is a hole in the atrial septum between left atrium and right atrium. The indication of the surgery is a volume overload when QBQS more than 2, or semi-TAR syndrome, or isolated partial anonymous pulmonary venous connection. Usually the optimal age above 2 years to avoid RV volume overload. The ventricular septal defect is a hole between the left and right ventricle. It's indicated when the symptomatic large VSD or moderate sized VSD more than QBQS more than 2. Observation less than this, we need to observe more than 2 years because small VSDs is liable to close spontaneously. The atrioventricular septal defect, this is the abnormalities of atrioventricular valve form and function with the communication, interventricular communication. The presence of atrioventricular septal defect indicated once diagnosed. When the partial atrioventricular septal defect can be done after 2 years of age, except if there is a heart failure or growth failure. Complete atrioventricular septal defect is better to be done earlier, after 3 to 6 months. Complete atrioventricular septal defect with refractory heart failure is indicated urgently, and development of vascular disease, if developed pulmonary vascular disease, is contraindicated. Pulmonary stenosis is a form of right ventricular outflow tract obstruction in which stenosis usually valvular or maybe valvular and subvalvular. Critical BS in neonates is indicated once diagnosed. Indicated for intervention, either percutaneous balloon valvotomy or valvotomy with cardiopulmonary bypass or transannular page. BS in infants and children is indicated with the symptoms and the pressure gradient more than 50. Surgical treatment is not indicated with the mild stenosis, only is for follow-up. Tetralogy of Fallot is characterized by underdevelopment of right ventricular infundibulum with anterior leftward displacement. Diagnosis once, indication of operation is once diagnosed. Symptomatic completed in early life, early total correction, or shunt if the pulmonary arteries are small, and later total correction. If asymptomatic and uncomplicated, total correction better than shunts after 6 months. If multiple VSDs or LED crossing, the RVOT is indicated for initial shunts and total corrections. We have tried to summarize all the congenital heart disease and concentrate on the main topics, and if later questions, we are ready to have any questions from the students. Thank you.